Hello, friend. Today we are going to focus on diabetic care in the hospital. The main goals in patients with diabetes needing hospitalization are 1. Minimize disruption of the patient's metabolic state. 2. Prevent adverse glycemic events like hypoglycemia. 3. Return the patient to a stable glycemic balance as quickly as possible. And 4. To ensure a successful transition to outpatient care. Rapid-acting insulin such as insulin aspart, insulin lispro, and insulin glucoside starts working in about 15 minutes. It lasts for 3 to 5 hours. You should teach the patient to inject rapid-acting insulin at home no more than 15 minutes before they eat. Short-acting insulin, such as regular insulin, starts working in 30 to 60 minutes and lasts for 5 to 8 hours. Rapid-acting insulin is the preferred insulin and can be more convenient to take than regular insulin because of the rapid-acting action. With regular insulin, you inject the insulin and then wait 30 to 60 minutes before eating. The latter can be inconvenient, especially since the objective of insulin therapy is steady-state blood sugar control. The goal of rapid-acting insulin is to prevent hyperglycemia after the meals. Intermediate-acting insulin, such as insulin NPH, starts working in 1 to 3 hours and lasts 12 to 16 hours. Long-acting insulin, such as insulin glargine, starts working in about 1 hour and lasts up to 24 hours. Long-acting or basal insulin gives you a slow, steady release of insulin. The goal of this insulin is to control your blood sugar throughout the day, between meals and overnight. Onset is the length of time before insulin reaches the bloodstream and begins lowering blood glucose. Peak time is the time during which insulin is at maximum strength. Duration is how long the insulin will continue to lower blood glucose. Teach people with diabetes that they should avoid multiple correctional insulin doses or insulin stacking by following the correct guidelines on administering insulin. This means using appropriate insulin doses based on current blood sugar levels and leaving enough time between them. Doing this can help prevent the risk of a serious hypoglycemic event due to overdosing. Insulin doses can then be adjusted over the course of the hospitalization based on inpatient conditions and variables as well as the patient's glycemic response. The fasting blood glucose is usually useful to gauge basal insulin replacement, while the pre-meal insulin addresses the short-term insulin demand to carb loading. The sliding scale method is more precise than fixed-dose insulin in that it takes account of the fact that people's blood glucose is not always in the normal range before meals. Sliding scale regimens may include a bedtime high blood sugar correction. The nighttime scale only considers the amount of insulin required to drop your blood sugar level back into the target range. It should not be used to cover a bedtime snack. All patients should have their HbA1c checked on admission to help differentiate between long-term and new-onset hyperglycemia. Check their most recent glucose labs and coverage. What do their values tell you? Is there good blood sugar control? Verify a hypoglycemia management protocol is in place. Is the patient compliant with their diet? Has diabetic education been completed? These are some of the questions you should ask during a good shift handoff. For most non-critically ill hospitalized patients with diabetes, we normally suggest a preprandial blood glucose target should be less than 140 mg/dl, while all other random glucose values should be less than 180 mg/dl. The preferred tissue space for insulin injection is subcutaneously, as it offers slow, stable, and predictable absorption. The usual places to inject insulin are the upper arm, the front and side parts of the thighs, and the abdomen. Don't inject insulin closer than 2 inches from your belly button. Thank you for watching this video. Please like and subscribe to our channel for more videos like this.